Good morning, welcome everyone to my 15 months progress report. I'm Robert Jonge and my topic is investigating the anterior cruciate ligament injuries and its effect on the knee joint. I'm a resident doctor at Uzsoki Street Hospital. My vision is to understand the nature of sports injuries and provide better care and life quality for knee injured patients. And I think we can do this by resolving disagreements and controversies of the anterior cruciate ligament injury and therapy. I have two ongoing projects right now. First one is comparing the operative and non-operative treatment of isolated ACL injuries. And the second one is adding an extra procedure to the reconstruction surgery. So let's talk about my first project. Rupture of the anterior cruciate ligament leads to instability, which is a major risk factor of osteoarthritis, which affects up to 15% of patients. In the US, there are more than 1,300,000 ruptures reconstructed a year. In Hungary, it was about 3,500 before the COVID pandemic. The gold standard treatment is surgical reconstruction, and conservative treatment is reserved as an alternative. Also, operative treatment is more common due to its associated improvement in knee stability. However, with a good rehabilitative treatment, we can effectively regain dynamic stability of the knee, as well as we can eliminate the risk of surgical complications. So, however, this is a really well studied field of orthopedics. We still do not understand which option is better to potentially prevent knee osteoarthritis after the injury. And basically our aim is to find out this. We have investigated isolated ACL ruptured patients with reconstruction, comparing them to conservatively treated ones, focusing on radiological and functional signs. We had more than 13,000 articles, of which only 5 made it to our final evaluation. So let's talk about results. First of all, radiological signs of osteoarthritis. There are clear signs of the degeneration of the cartilage, and there is a clear cutoff value between normal and osteoarthritic knees. On this first plot, we can see that there is 1.84 times higher odds to have a normal knee for reconstructed, non-reconstructed, so conservatively treated patients. However, this is a non-significant difference. The second one is arthrometry, which measures the anterior translation of the tibia and comparing the injured and uninjured extremity. Basically, this measures the laxity or the stability of the knee joint. In this plot, we can see that the reconstructed knees are more stable, so there is less laxity by 2.44 millimeters compared to the conservatively treated ones, and there is a significantly better stability for the reconstructed patients. The third one is LISOM score. It's a patient-reported outcome, subjective score from 0 to 100. Which measures symptoms and activity of the patients. Here there was a 2.88 difference in favor of reconstructed patients. However, there was no significant improvement compared to the non-operated patients. So as a summary, the radiological science favors conservative treatment. Arthrometry has a significantly better stability for the reconstructed group. However, basically this is the goal of the reconstruction, to have a more stable knee, so this is not a big surprise. And in the LISOM score, we interpreted that there was no mathematical difference and only less than 3 points difference in a scale from 0 to 100, we interpreted this result as it favors conservative treatment. So basically there is no need for surgery if just there is a small difference like this. These were all of our outcomes. We could only analyze the underlined ones mathematical because for all the others there were no enough data to do a meta-analysis. This is quite an important notice for all the studies and for future study designs. As well, we could manage to create a table of the subsequent injuries and surgical interventions needed during the follow-up period. So basically the strengths of our study is that this is the most comprehensive literature review available until now. Also, our findings and suggestions could serve as a recommendation for study designs and may affect guidelines in the future. Of course, there are limitations. We had just a few studies with really different outcomes, as I showed before, because of the poor data reporting across the studies, and we had only 2 RCTs included. Also, ACL reconstruction techniques were heterogeneous among the studies. So the conclusion is that non-operative treatment could also be an option for this specific subgroup, the isolated injured ACL. Patients for the practice, we should consider starting with a non-operative treatment primarily. Then if it's not enough, then we could switch for the operation. And for the research, more RCTs are needed with good and standardized research protocols, as well as studies with more specific populations like elite athletes are needed. So basically this is the progress, which doesn't show the effect of, which doesn't show the amount of work we have put in the last few months. But I can say that our article had been submitted to the Osteoarthritis and Cartilage journal, and this is under review right now. This journal is a D1 in orthopedics with quite an impressive impact factor. So we hope it will be accepted. As the second project, as I said, ACL injury is one of the most common knee injuries, and the gold standard treatment is anatomic single bundle reconstruction, which has good to excellent outcomes. However, up to 25% of patients experience residual rotational instability, which leads to poorer outcomes. Therefore, anterior extra-articular procedures are considered as an additional process to reduce this rotatory laxity. And our aim is to find out if this is superior to reconstruction alone. And this is our clinical question. We are investigating patients attending ACL reconstruction plus the extra-articular procedures compared to them to reconstruction alone, and focusing on knee stability, functional outcomes, and graft failure, which is associated with revision rate. Our hypothesis is that with the anterior extra-articular procedures, we could decrease this instability, which leads to better outcomes and lowers the rate of the revision surgery. We would like to improve knee stability, shorten the return to play time, and improve graft survival in the clinical practice. We have done the systematic search. However, it was done quite a time ago in April, and since we were focusing on the first project, there are a lot of new studies that has been published. So we are planning to redo and expand this search in the early next year, and we will do the title and abstract selection of it. So this is the 2 projects. We have submitted the first one, and we are planning to submit the second one in the middle of 2023. Thank you for your attention. My motto is the same, that only time I set the bar low is for limbo. Thank you very much.
My question would be that, based on your results, would you change the standard of care for young patients as well? So as you mentioned, what you normally do is that for younger active patients, you do the ACL reconstruction surgery. And based on your results, you said that conservative treatment might be just as effective. So do you think it's possible in the near future that advise for these young patients as well, the conservative treatment?
Thank you for your question. This is really important. Actually, as I said, we have only limited data on these results. However, for a young patient who has isolated tear and there is no significant subjective feeling of instability, then I would say yes, let's start with conservative treatment, let's start with rehabilitation, and if we can't achieve a good dynamic stability, then I would say that yes, do the reconstruction. That's why I think it's really good to start with conservative treatment, because we could always switch the treatment protocol.
Thank you.
Congratulations, Robbie, actually, fantastic. Actually, I have a comment regarding to your previous answer. So don't forget that in your study you were investigating the radiological outcomes, not the other one. So your conclusion is based on that part. And I was just wondering whether, of course, osteoarthritis is a very important outcome, and it's very hard to investigate, because it will happen in long term. Of course, I know those results or the other projects where you can show that after a couple of months or years, you can already see the changes. However, that clinically important osteoarthritis when can happen. So I was just wondering whether can we really measure this, or how good is this outcome, or how relevant?
Osteoarthritis?
Yes.
Well, this is quite important and quite relevant, because this is the degeneration of the joint, which affects the range of motion, the quality of life, and in the longer term, when there is the final stage of the osteoarthritis, it will be needed a total prosthesis, and which is quite a big surgery for the patients, and it is really expensive for the healthcare as well. So we are trying to minimize these osteoarthritic changes and protect the knee.
I'm 100% sure that this, I mean, of course, it's very important to prevent this part, but this will happen in years. So can we be sure that this is the reason why we prevented it, or some of the patients won't have osteoarthritis, or they will have later?
Yes, for this, there are studies which compare both sides of the knees of the patients, the injured one and the uninjured one. And with this comparison, we could tell if there is a higher progress of osteoarthritic changes in the injured knee or not. This could be a really good project for later.